Okay, John, are you with us?
Yes, I am.
Okay, so let's talk a little bit about inflammatory arthritis, uh, uh, kind of in general. So I can talk a little bit about the historic perspective, and I'm going to primarily talk about rheumatoid arthritis. And this is a little bit more of a pathophysiology and historic talk, so that, uh, and we'll talk a little bit about the role of mRNA, but it didn't turn out to be what I thought it was going to be when we first started getting into this area. So this is a patient who has long-standing rheumatoid arthritis. What you can see here is that there's marked destruction of the digits. Especially in this case, this patient had severe erosive RA, where the bones were mostly eroded, and obviously these hands are not very functional. So, uh, yeah, and as I said earlier in previous lectures, up until about 1990, the drugs to treat this were very ineffective and toxic. And with the development of low-dose methotrexate, 1990, really the whole treatment for rheumatoid arthritis really changed. So the treatment called what are called disease-modifying anti-rheumatic drugs, of which there are a number now. In the old days, when I was growing up, we used gold, which you basically gave as much as you could till it was toxic, and then steroids, which had terrible side effects, and aspirin really was not very effective. And then methotrexate came around. Before 1990, the methotrexate was used in large doses for really kind of end-stage cancer. So it's kind of the kiss of death if you went to methotrexate. So I was very surprised when they started using it for rheumatoid arthritis, but at lower doses, it's not as toxic as it was for cancer. It's relatively inexpensive. And then in around 2000, the biologic agents came out, which are much more expensive but highly effective, especially for erosive disease. And just to remind you, non-steroidal anti-inflammatory drugs, and if we're really talking about this form of inflammatory disease, are really not helpful at all. So this is just some data here where we can see uh, oh, right. So if this is basically a change from baseline and looking at erosion or sharp scores, which are a scoring of symptoms in the disease of rheumatoid arthritis. With methotrexate, and when you institute it, it can actually change the course, and it slows progression. But especially with erosive disease, if you add etanercept, which is one of the first of the antibody agents against inflammation, you get marked uh, improvement in progression. So generally what's agreed upon is the long-term disability in rheumatoid arthritis strongly depends upon the amount of bone destruction. Not everybody who gets rheumatoid arthritis gets erosive disease, but those who do have the worst prognosis in terms of disability. Without therapy, about 50% of patients will go on to erosive disease and deformity due to that. If you use DMARDs, they're very effective at slowing, or in many people, they just stop erosive disease. And therefore, early diagnosis and treatment really has been shown to improve outcomes. In fact, this is to the point where a number of years ago, the criteria for diagnostic rheumatoid arthritis completely changed, and I'll explain how that happened. So first, I'd like to talk about the pathogenesis of bone destruction in rheumatoid arthritis. It typically starts with synovial inflammation within the joint. Then what happens is that you get replacement of the marrow adjacent to the joint. And as we'll talk about, it primarily starts where the capsule inserts on the bone, and there are a couple of theories as to why it starts there. And then histologically, what you see is a replacement of the fat within the marrow space at that location by inflammatory cells. So it's a true osteitis. The inflammatory cells exude chemicals that dissolve the trabecular bone. So that causes destruction of the trabecular bone due to a true inflammatory response. You get destruction, then first you get destruction of the trabecular bone, then it goes on to destroying the cortical bone at the joint margin, and then it will extend, as I'll show in a minute, to destruction of the subchondral bone, at which point the articular cartilage becomes destroyed. And then that leads to cartilage and joint destructions. So if you look at several different phases of this, in the acute phase, you get inflammatory cells, and in the soft tissues, and you get neovascularity. You get a positive power Doppler and a positive perfusion MRI, and this is very high activity. Now, what's a perfusion MRI? A perfusion MRI is where you do a MR scan before you give the contrast. Then you start do MR within 30 seconds after giving the contrast, and you image while the first phase of contrast extends into the soft tissues. So it's you're really looking at perfusion with this technique, and if that's positive, you really have very high activity. And those patients will tend to respond very well to the TNF-alpha inhibitor drugs. You can get a subacute inflammation, which is usually later. It's getting to the point where the inflammation is starting to burn out. You get more stromal cells and actual capillaries rather than neovascularity in the lesion. You can see this with ultrasound and contrast MRI, where it enhances with contrast because you get leaky capillaries, and this is moderate activity. And finally, you get a chronic disease where you have few inflammatory cells, but they're really replaced by fibrous tissue. Ultrasound, we can see an abnormality. MRI, we can see the fibrous tissue and changes, and this is kind of old, burned out disease. We'll show examples of these. So this came from a study that we published in Arthritis and Rheumatism, and this is, we did an MR scan, and this is 12 seconds. This is on a 1 Tesla scanner, similar to what Dr. Stone has. And what we can see here is there's synovial thickening around the second and third metacarpophalangeal joints. At this stage, maybe there's a little bit of enhancement here, but basically we don't see much enhancement at 12 seconds. If we go to 24 seconds, we can start seeing the enhancement. So this would be a positive perfusion study by MR, which places the patient as an active patient at high risk for destroying their tissues. And this is at 36 seconds, where you can see marked enhancement in the area where you have the active inflammation. And this is all because of neovascularity, which is very leaky for contrast going into the case. So that's a positive dynamic enhancement. So we did a study looking at this. Other people have as well. Not commonly used anymore. Also, Doppler ultrasound, you can see a lot of high perfusion here in this case. So it has to perfuse within a few seconds after you inject it to be a positive perfusion study and this very active synovial disease. Then what you get is marrow infiltration. And what studies have shown is that you get inflammatory cells replacing the fat cells in the bone adjacent to the cortex where the capsule attaches. MRI shows increased free water. Really, it's called bone marrow edema. And the rheumatology literature, which isn't technically correct, but that's what it's typically called, bone marrow edema. It's highly predictive of bone destruction. 6-year follow-up from studies done by McQueen et al. In arthritis and rheumatism. The histologic studies, a number of people have done histologic studies to show that the initial lesions is really replacement of the fat by inflammatory tissues. So this is using a 0.2 Tesla desktop in-office scanner. What we can see here on the T1 weighted image is a little bit of loss of fat signal here, where the fat is being replaced by non-fatty cells, and we can see some edema on the stir technique right here. So this is a typical appearance of the early inflammatory lesion in rheumatoid arthritis. The subchondral bone is still mostly intact here, so this isn't a true erosion. CT and X-rays would be negative in this case. So we get what looks like edema. Again, it's not true increased water in the interstitial space, which is what edema is. It's replacement of fat cells by cells that primarily have water in them because they're inflammatory cells. It tends to have indistinct margins, and it's located near the joint capsule. This stage, we and others have shown, is reversible if it's treated right away, and it's most specific for rheumatoid arthritis. Yeah, one study showed that high field is much better, but other studies went on, as long as you use the proper technique, the field strength really is not that important in this study that we published in Journal of Rheumatism. And this just shows an area where we can see a little on a low field scanner. This is a non-uniform field desktop scanner that you just put your hand in, and this is the size of the field of view that you see. And it allowed us to see a little bit of edema on this T1 weighted image in through here. That's really a normal area on the CT scan. So what we found is that these early lesions, osteitis, you really can't see by X-ray techniques. Now, what we'll see is a progression of stages of destruction in rheumatoid arthritis. The first stage, you really see replacement of the fat by inflammatory cells, indistinct margins, as we hear next to the cortex, typically near where tissue is attached to the bone. Then a later stage, you see it sharply demarcated with an area of high signal intensity on the fluid-sensitive images. And then the later stages, it becomes very dark, where it's filled primarily with fibrous tissue, and those are end-stage, typically stable lesions at the end stage of rheumatoid arthritis. So, and there we can see an early osteitis, and this is kind of the end-stage disease after the inflammatory cascade has burned itself out. Now, I think a critical part of all this is the importance of what happens to the trabecular bone. So again, the histology studies have shown what happens is that near the insertion of the capsule to the bone, the first thing you see on histology is a replacement of fat by inflammatory tissues. And then what you then start getting is in the middle of the inflammatory tissue, you have a dissolution of the trabecular bone. And as the inflammation increases, you start with maximum degradation of the trabecular bone in the center, and then it gradually moves out. So what you want to do is make the diagnosis as early as possible, stop the inflammatory process, and stop the destruction of trabecular bone. Now, if you fracture a bone, what happens is that the cortex, you put it back together and you put it in a cast. The periosteum grows over the area of the fracture of the bone. It acts as a substrate then for the cortex to heal itself and heal the fracture. Inside the bone, if you destroy the trabecular bone, these are 3D plates and struts, as we saw from a previous lecture about osteoporosis. If you destroy those, the body does not store a 3D display of where its trabecula is supposed to go. So once you destroy the trabecular bone, the body can't regrow it again. What happens is you thicken the trabecula around the area of destruction of the trabecular bone, and you can see that as an area of sclerosis on X-ray based techniques, and you'll end up with a hole in the middle, and we generally call those geodes, or a cyst within the bone. And that's kind of the way they heal. The larger it is, the bigger the destruction. Now, if you have areas, what we'll see here is that commonly with rheumatoid arthritis, You can get areas where in the very center you've destroyed all the trabecular bone. Around the edges, you've thinned the trabecular bone, but it's still there. If you stop the inflammation, then those partially destroyed trabecula can't heal, and you only end up with a hole in the center where you completely destroy the trabecular bone. So the sooner you get to it, the better. And we'll come back over and over again to that theme in talking about rheumatoid arthritis. Now, one thing that's important is that the rate of destruction is measured in weeks, not years. So if you delay a month or two in treating the patients, you can have a much larger irreversible defect than if you treat it immediately. So waiting a few months is actually a bad thing to do with rheumatoid arthritis. So early detection is really very important. So just let's look at them. Again, these are some low-field scanners because most of the work we did were with MR scanners that were in orthopedist office, rheumatologist offices because that's where the patients were. And so let me see, who's next? Elior? Are you next? Robert? Robert? Okay, Robert. What do you think here?
So it looks like there's an erosion in the distal ulna, some increased signal on the fluid sensitive imaging.
Okay, so there's the stir. Here's the T1.
Mm-hmm.
And actually, for these lesions, surprisingly, this is actually a gradient echo T1.
Okay.
In a low field scanner, this is 0.2 Tesla scanning, it actually works out very well in these patients, surprisingly, because we can do gradient echo images that are 2 millimeters thick, that are continuous with one another, and we have very good contrast at low field. If you did this technique at 1.5 or 3 Tesla, the contrast is terrible and you really can't see very much. So there are rare advantages of low field scanning. In fact, this was one of them. Unfortunately, with low field, we don't get very good quality on the stir images, but that's all we're looking for is whether it's bright or not. Mm-hmm. The actually details of the morphology we see very well on the thin cut continuous gradient echo images. Okay, so we see a lesion there. So the patient then was put on a TNF-alpha inhibitor, etanercept, I think in this case. We imaged them a couple of years later, or a year and a half later. What do you see here?
Yeah, it looks like it's decreased in size substantially.
Okay, so how can an erosion decrease in size? How's it gonna heal itself?
That's good. I mean,
So what happened is you've destroyed all the trabecular bone in the center, but around the periphery of this lesion, the trabecular bone is still intact. It's just not normal. So when you stop the inflammation, the periphery has a chance to heal, and you go back to this, and only that center where you destroyed all of the trabecular bone is not able to heal. So again, it's important. The sooner you treat it, the importance, and it should be measured in weeks or maybe months, but not years. And we'll come back to that. So this is a study that we published in Journal of Rheumatology. We found that about 15% of erosions in patients who are newly diagnosed with erosive rheumatoid arthritis, actually we can see a significant improvement in the erosions using MR scan. And we thought that this was consistent with this gradient of injury that I was just telling you about. So now let's go on to cortical destruction, because that's classically what we start seeing with CT and with plain films. And when I grew up in medicine, it was thought that the erosions occur in the so-called bare area, which is between the articular cartilage and the insertion of the capsule in the bone. Because it was thought that the articular cartilage and the insertion of the capsule actually protected the underlying bone from the inflammation and erosion. So that was the classic area. And we know that MR is better at looking at these. So this was a study by McGonigal, who's a pathologist in England back in arthritis and rheumatism in 2007. They re-looked at this area 2 years later, looking much more precisely at exactly where these erosions occur. And they actually don't occur in the bare area, where I taught and almost most people were taught up until this paper in 2009. They actually occur right adjacent to the attachment of the capsule. And why is that? Well, there are a lot of theories. We don't really know. Well, one theory is that the inflammation starts in the synovium, that where you have attachments, and by the way, the erosions tend to occur most frequently in areas where you have the largest amount of stress on the capsular bone interface, like the second metatarsal head. And that these may occur from cracks in the cortical bone and allowing inflammatory cells to extrude through the cracks into the underlying trabecular bone, where they then magnify and replace the fat. The other theory is that you don't actually have cells migrate through here. What you have are inflammatory molecules that diffuse through. And when you get these inflammatory molecules in the fat adjacent to the cortical bone there, that this is then picked up by the body as abnormal biochemicals, and then it induces an inflammatory reaction in this particular area. And it may be due to little cracks within the cortex, which allow either the cells or bioactive chemicals to diffuse into the medullary bone and induce the inflammatory reaction in that location. Okay, so then we did studies comparing X-rays to MR scans and looking for these lesions. What do you think, Elior?
Okay, so I think looking at the ulnar aspect of the second metacarpal head, there's,
Right in here?
yes, or yeah, a little more distally. Is there a little bit of a curvature there?
Here?
Yes. No?
Okay. How about let's go to an MR?
Sure.
That's the X-ray. Here are the MRs. So there's the X-ray there.
Uh-huh.
There's a little something here.
Okay.
But we can clearly, on a very low quality, low field, again, these are a desktop scanner, actually scanned in a non-uniform field of view. And we can see that there's an erosion on the
Anterior.
inside. So thank you, John, for reminding me. We can see that there's an erosion here, which corresponds to this area. I still, in retrospect, wouldn't call it. And there's also an erosion over here, which is in this particular area there. So, so I actually looked at 40 RA patients and we compared them to 40 healthy controls. So we looked at 3,360 bones. What we found is that a single erosion was 90% sensitive and detecting rheumatoid arthritis, but only 35% sensitive. So a single erosion, if you just have a single erosion, most of the time it's going to be degenerative disease in this particular area. If we saw osteitis based upon its T1 and stir characteristics, it was much less sensitive, but much more specific for rheumatoid arthritis. Now, if you eliminate the lunate, then the sensitivity decreased a little bit, but the specificity got much better. And that is the reason for that is ulnar abutment is so common in these wrists that you don't want to misdiagnose ulnar abutment for an inflammatory erosion. So our conclusion was that MR could be quite useful at detecting patients with erosive disease, which in those patients then have strong indications to immediately be placed on anti-rheumatic drugs. So now we go on to the next stage of disease is destruction of the subchondral bone. And there, I really believe, looking at thousands of these erosions, that you start with the erosion, with the osteitis. That osteitis then starts eroding the margin of the bone and then kind of breaks through the cortex. And here we see a typical example. There's degenerative disease there, looks very different. This is a marginal erosion, could be degenerative or could be rheumatoid. But if we follow this over time, what you see, it starts out here, and then it starts growing underneath the subchondral bone. So here it's not near the subchondral bone, it's at that capsular insertion, which is where McGonigal and their group found that these typically start out. And then what happens is that then the inflammation grows in the subchondral bone, destroys the subchondral bone, and that leads to destruction of the articular cartilage of the joint space. So again, we want to pick these up early and stop the erosion since we now have drugs to do that. What happens if you don't? Well, here's a typical example. In the old days, a typical finding for rheumatoid arthritis was called pencil and cup disease. Here's the pencil, and there's the cup. And what this is erosion of the bone, typically on either side, with only the center of the bone still present. And here we can see the erosion started over here, gradually moved along the subchondral bone, maybe a little erosion on the other side as well. And here's the pencil, and there's the cup. Marked loss of articular cartilage in this particular case. So this is the way you destroy the joint, typically with rheumatoid arthritis.
And that is a synovial tissue that is hypertrophied and then producing abnormal fluid
Mm-hmm.
that I think adds to the destruction of bone also,
Right.
and the pressure inside the capsule. So it's because it starts right in the margin of where the capsule attaches to bone and the synovium attaches to bone.
Good.
So that's usually where it starts, right, John?
Right. Definitely.
So then the pressure and also the growth of the synovium and the abnormal fluid is a very destructive substance, which I remember saying many times. It was how ugly it was when we used to do synovectomies,
Right.
which are still done.
Thanks, John. And this is just an example where this has gone on without being treated, and you get massive destruction of the wrist. Rheumatoid arthritis.
Those spaces are not where you don't see the bone are not empty air or whatever. It's synovial,
Right.
abnormal synovial tissue.
Right. It's all pannus. Right. Okay. All right, let's talk about some of the other disease processes that we can be by rheumatoid arthritis. Olga? Well, actually, here, let me. So one of those are bone fusions, and here we can see multiple fusions in this wrist. And I want to talk about how these fusions occur with rheumatoid arthritis. Okay. So here's a 71-year-old female. Okay, so what do you think's going on here? So this is a T1 gradient, and this is a stir.
So there is a edema.
Okay.
I mean, in carpal.
Good. Okay. So what we see on the T1 weighted image, we see a loss of the normal fat signal, and that's because the fat is being replaced by the inflammatory cells that we just talked about. And you can see it's brighter here because those cells have predominantly water and not fat in them, and therefore they're going to be bright on the stir sequence. This was on 12/6/07. The patient was placed on methotrexate at this time. Notice if we look here between the capitate and the scaphoid, sorry, we can see the nice cortical margins on both sides are still intact on the T1 gradient echo. And we go to the axial image, we can see the joint space is still intact. So this is on 12/6/07. The patient was placed on methotrexate. The inflammation got better, and the patient now came back a year and a half later. What do you see here?
Like bone fusion, like.
Okay, yeah, I guess it says joint fused there. I'm sorry. I said, right. You're right. I agree with you. I agree with you. Yeah, right. I just noticed that it was there myself. So, and if you notice that the edema's gone away on these poor quality stir sequences. So what happens is with this inflammatory reaction, you destroy the cortical bone. When you stop the inflammation, bone loves to heal. We've talked about that. These two raw pieces of bone are right next to each other. So what do? They fuse. That's what bones like to do. They like to heal themselves. And yet with a bone fusion, on the axial image, we can see the joint space is completely gone now. And so the patient now has a fusion. And I think that's how the fusions occur in rheumatoid arthritis.
The cortex is destroyed.
Right, exactly. So that's how fusions work. This is another case where we have ulnar impingement. Ulnar impingement classically can be done by rheumatoid arthritis, where you erode the distal end of the ulna, becomes unstable, and you have the bone of the ulna rubbing against the distal radius, producing this kind of erosion. The other thing that this can happen is if you do a surgical resection of the distal ulna, then you'll have the same mechanism which produces this erosion. So this is ulnar impingement as opposed to ulnar abutment, which has to do with the lunate. So other things that we look for in rheumatoid arthritis, looking at the soft tissues, we looked at ligament laxity because the inflammatory process invades the ligaments and tendons, messing up the biochemical makeup of the collagen. I think I've got some slides on that in a minute. Then the ligaments tend to then become more lax, and you get instability, which can also lead to degenerative change of the joints. So we get ligament laxity, you can get tenosynovitis, and then there's some named deformities that we'll talk about due to this soft tissue process. So one of the common things which is pretty diagnostic of rheumatoid arthritis is a very characteristic subluxation which occurs at the metacarpal phalangeal joints, where the proximal phalanges sublux anteriorly and proximally on the metacarpal heads, and that's due to injury of the collagen fibers of the capsule here, making it unstable. The flexor tendons are stronger than the extensor tendons, and they pull the fingers volarly and proximally, as we see here. So that can be very helpful if you're concerned about a difference.
Is this an index finger, John?
I don't know which one it is, John.
I can't tell either. Index fingers, if they're in this situation, you cannot reduce them clinically.
Okay.
You have to do surgery.
The index is the most common.
Anytime you get a MP, subluxation or dislocation in the molar, this is a real problem for the index finger. All the other fingers you can reduce, but this one you cannot.
Okay.
That's because of the anatomy.
Yeah. The other thing you can get is tenosynovitis. Again, these are the low field scanners. We can see a lot of the synovial thickening around the tendons, the ECU in this particular case. This is all synovial thickening, and the ECU is extremely commonly involved. Now, typically in younger people who have trauma, if you have instability of the ECU, it's very symptomatic. In older patients with rheumatoid arthritis, virtually all of their extensor carpi ulnaris are abnormal, and it's extremely rarely to be a cause of one of their major symptoms. So it's a very different process in older patients with rheumatoid arthritis than young patients with trauma.
One other thing, John, is I've seen many cases clinically at surgery. The skin becomes very, very kind of loose and very thin, almost paper thin.
Right.
I'll never forget a case that we were just finished operating on, and I had the calf in my hand with this female, and she started to struggle because she was coming out of anesthesia, and
Yeah.
I squeezed the calf, and my fingers and thumb went right into the
Oh
gas
my
rod.
God. Oh, that's terrible. And that's just a typical example of a deformed ECU, which is subluxed, which is almost all patients who have had rheumatoid arthritis for uh, a few years, especially when they're older, you're going to see this kind of ECU dislocation. I always comment on it, but we did a study looking at how commonly these patients are symptomatic, and basically, it's never a major
We
cause
call
of
that
symptoms.
ulnar drift.
Okay, ulnar drift. All right.
All right. Well, yeah, the PIP is flexed and the DIP is extended. Um, is this a boutonniere
There
deformity?
you go. So that's called a boutonniere deformity. It's another classic deformity in rheumatoid arthritis, but can be seen in other areas. A lot of these can have an A2 pulley tear, producing separation here, making uh, basically when we get to we'll discuss the pathophysiology of how this occurs when we get to the hand and wrist lectures, and then and tend to get extension of the DIP, and these are kind of fixed deformities.
All right, so this one, the PIP looks like it's extended, and is this swan neck deformity?
Okay, right. So there, a little flexion, and here, what you see, what causes this is displacement of the extensor tendons. But again, we'll talk about this in more detail when we go through the anatomy of the hand. And you get subluxation again because of the destruction of the ligament and capsular structures that hold the tendons in proper position because of the inflammatory disease. And that's this one.
The flexors become extensors.
Yeah, right. Okay, Elior. This is the thumb.
Uh, okay, so do we have? I'm trying to figure out what direction. We have ulnar subluxation of the first
What you have,
phalanx, and
basically extension of the phalangeal joint, flexion of the metacarpal phalangeal joint. And see displacement again of ligaments. That's the left side. This is the right side. So what would this person be really good for? Oh, wow.
the hitchhiker.
Yeah,
The what?
that's a hitchhiker's thumb. Okay. All right.
Oh, okay.
That was a hitchhiker that was hit by a car.
With our rheumatoid arthritis.
Um, so it's like joint space narrowing and
Okay.
at the
Right space narrowing, a lot of subcondylar cystic changes, so a lot of degenerative disease here. Fusion, maybe a little synovial thickening. This patient has had long-standing JRA. And what's happening down here?
What's happening down here? Like lymph nodes, or what's that?
Sorry, what?
Lymph nodes.
Okay, so it looks like they're lymph nodes. If we look at sagittal image, we can see there's a lot of this lumpy, bumpy synovial thickening. And these are rheumatoid nodules.
One thing about this children's RA, they're very sick to begin with. They're high fever, and and then the swelling of the it may start with just one joint, and but they're very sick. I remember when all we had was aspirin. We used to give aspirin until the ears would ring,
Yeah,
and
right.
it still wouldn't help the pain. So I had to go to morphine and so on.
Yeah.
But
And
JRA is a miserable condition in kids.
yeah, and the term juvenile rheumatoid arthritis is kind of frowned upon in this day and age. And if you can't make a specific diagnosis with, we'll talk about the criteria.
Not a good way to start life.
Right. It's just it's just considered rheumatoid, just considered liking the name of it right now, kind of a non-differentiated arthritis in younger people. Then, but you need to look at it aggressively. And if we start seeing synovial thickening like this, osteitis, and especially erosions, then it's got to be treated like rheumatoid arthritis to stop for the reasons we talked about before. So why don't we stop here and we'll finish this lecture. It'll probably take us about another 20 or 30 minutes next time. Okay.
I won't see you until Friday, John, if you're going to be around, or otherwise it'll be Monday.
Okay, I'm glad you brought that up, John. So we will not have a lecture on Friday, and next week we will not have lecture on Monday, Tuesday, or Wednesday. So
So I won't see you until
till Thursday, a week
from Thursday.
Yep. Okay. Thank you.
Okay, take care of everybody.
Yeah, they just changed it to
Stay out of trouble.
juvenile idiopathic.
Yeah, juvenile
arthritis,
idiopathic. That's what I was trying to say. But yeah, good. Thank you.
Designated driver.
Okay, John. Thank you.
Take care.
Yeah.
Happy Thanksgiving.
Same with you. Thank you.